Hello, everyone. It's a real pleasure for me to be with you today and talking about a very interesting topic that is the ovarian stimulation for cycles of IVF and ICSI. My name is Dr. Espina. I'm the medical director of the clinic in Bogota, and I'll be here available for any doubt or a question that you could have around this interesting topic. Okay, let's start with this lecture today. And first of all, it's important to understand what is the definition about ovarian stimulation. And I can tell you that this is a pharmacological treatment with the intention of inducing the development of ovarian follicles. But we have two main purposes when we do this treatment. The first one is planning fertile intercourse or insemination. And the second one is to obtain multiple oocytes at the moment of the follicular aspiration. Today, we will talk about the second point is how can we obtain the best quality and the best quantity of eggs during a process of IVF and ICSI. If you evaluate the evidence about this topic, you will find that there is a lack of guidelines about this specific theme. Some societies has been proposed some statements, for example, the NICE guideline and the Royal College of New Zealand. And even in 2017, the WHO made a review of the evidence, but in this document, you will find no recommendations for the correct way to do the process. But in 2019, the Ashram Society, who is the Society of the European Embryologists and Reproductive Medicine, they made a beautiful publication. This is in the right side of the screen, ovarian stimulation for IVF and ICSI. If anybody of you are interested in searching more deeply this theme, I will recommend you this document. Okay, it's important to remember what is the definition about infertility. And infertility is a disease, and it's important to know that. For many years ago, the WHO considered the infertility like a disease, and maybe that changed in some point the way that we look and the way that we treat the infertility. And this is a disease that could affect the male or the female reproductive system and is defined by the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. In the last year, 2023, the WHO made this publication about the prevalence of the infertility around the world. And what can we find in this document? If you see here, the prevalence as the classic concept that we have is around 12% in the general population. But in the left side of the screen here, you will see a new concept. And this new concept is the lifetime prevalence. And what is that? It means that 17.5% of the population could have or could experience some type of infertility during their lives. That means that 1 in 6 people could have infertility in some moment of their lives. That means that we have a lot of people with this problem. We have a lot of couples with infertility, and that is important to understand the impact that this condition could have in the general population. Okay, let's talk about the main steps for ovarian stimulation. And I can give you 5 steps for this process. What is the first one? We need to do a pre-evaluation of the patient before to start the stimulation. The second step is to establish the ovarian stimulation protocol. The third is selecting the medication for blocking the LH surge. The fourth is to choose the ideal medication for triggering the maturation of the oocytes. And finally, the fifth is define if the cycle will have fresh embryo transfer or freeze-all. Okay, first step, pre-stimulation evaluation. Remember that before to start the medication of a patient, it's very important to be sure about the ovarian reserve of the patients. And we have 2 main tools for do that. The first one is the AMH in the left of the screen, and the second one is the antler follicle count in the right part of the screen. If you see the criteria in these both tests, you will find that there is important classification about the patients. You can have a patient with a high ovarian response or poor ovarian response. And it's very important because according to this information, you can select and you can choose what is the ideal protocol for start the stimulation of the patient. There is a threshold and it's the same point for AMH and antral follicle count. If you see here, if you have 15 oocytes or more, you will have a high risk for having a high responder patient. By the other hand, if you have 4 oocytes, you will have a poor ovarian reserve or a risk for obtaining at least a low number of oocytes during the stimulation. And the numbers are equal for AMH and AFC. And the conclusion is that for predicting the response of the stimulation, the AMH and the antral follicle count maybe are the best tools that we have right now over other ovarian reserve tests. What are other interventions that we can do before the stimulations? We can use, for example, progesterone, or we can use estrogens or GnRH antagonists. In some protocols, you will find that these medications could be theoretically useful for the treatment, but the evidence show that there is no difference if we use some of these medications before the stimulation. But there, we have here a very, very useful tool, and is the contraceptive pills before the ovarian stimulation. And what is that? You know that we have a lot of patients that are coming to our clinics from other countries or other cities, and it's very useful for the doctors that are sending to us the patients to use the contraceptive pills before the beginning of the stimulation, because that could give us the advantage for scheduling the beginning of treatment. For example, if the patient wants to come to Colombia in a specific week or a specific month, the doctor can give to the patient contraceptive pills before the ovarian stimulation, and that could be very, very useful for you. Second step, to establish the ovarian stimulation protocol. And here, we must do a rating of these patients in 3 groups: high responders, normal responders, and poor responders. And that is very important because according to this stratification, you can select what is the best stimulation protocol that you can use. In the first group, high responders, you can use antagonist or you can use agonist for the blocking of the LH surge. And it seems at some point that the antagonist could be a better option comparing with the agonist, because you will have a higher risk of hyperstimulation when you use agonist. That is the reason because we prefer the GnRH antagonist in this type of patients. In some moment, we used letrozole and clomiphene for theoretically improving the response of the patients, but finally we know that there is no difference between oral inductors of the ovulation versus gonadotropins. We prefer to use agonist or antagonist and gonadotropins and not oral medications. The low dose of gonadotropins are preferred versus high dose, obviously, because in this specific group, we want to have a normal response, no high response, and that's the reason because we prefer to use low dose of gonadotropins. The second group is the normal responders. In this group, also, we prefer antagonist versus agonist, considering the safety of the treatment and the results, and also because maybe the treatment is more comfortable for the patient because we will use less injections compared with the agonists. To add letrozole or clomiphene to the treatment, that will be the same result. That is not recommended in these patients. And normal or high dose of gonadotropins are preferred in this patient because we want to have a lot of effects in this group. Finally, the poor responders. And remember that this is the group of patients with less number or low number of oocytes. There is no difference using GnRH antagonist or agonist. That is what the evidence showed to us. But some studies show benefits with agonists, but it's not conclusive because, the agonist could give us the flare-up effect, and theoretically we can have more oocytes if we use agonists. But the evidence, I insist, is not conclusive about this topic. If we add clomiphene or citrate or clomiphene citrate, there is no difference. Letrozole doesn't improve the results, but some studies show that clomiphene could be a little useful in these patients. And finally, this is very important, the dose of gonadotropins is very important because in some areas or some countries around the world, some people recommend to use 400 units or 500 units, and there is not true. If we use 300 units is enough for having the same response in any patient. Then now appears other question about the types of gonadotropins. Is one better than the other? And you will find a lot of information about this topic, but I can give you these 4 sentences. But in summary, there is no difference between FSH, recombinant, or urinary compounds, or HMG, in terms of number of oocytes, fertilization rate, and implantation rate. Pregnancy rate is very similar between one gonadotropin and the other. Letrozole and clomiphene don't show advantages versus gonadotropins in high complexity treatments. That means that we prefer to use only gonadotropins in these treatments. But in some publications, you can find some certain advantage when using LH in patients of 35 years or more. But that is not conclusive, right? That could be maybe a personal recommendation. When I do a stimulation of a patient of 35 years or more, I prefer to use LH because there is some evidence that shows that we can have more maturation rate and more quality effects when we use LH. This is my personal advice for you. Third, we need to select a medication for blocking the LH surge. And we have these 3 options. We can use agonists, antagonists, or progesterone. The agonist is less used today. There are a few controversial indications, for example, in poor responders, considering the flare-up effect. But if you decide to use it, please opt for long protocol. It means that you should start the agonist in the middle luteal phase in the previous cycle to the stimulation. The second group, and maybe this is the most common medication that we use for the blocking the LH surge, and it's the antagonists. It's recommended over agonists because there are efficacy and higher safety comparable with the agonist, but it's more comfortable, less injections, and the final result is very similar. And finally, there is the recent option, and is progesterone, just tablets or pills. You can use pills for blocking the LH surge, but there is lack of evidence because we are using progesterone maybe from 4 or 5 years ago, no more than that. But if apply the progesterone, they can only be used in non-fresh transfer cycles because obviously the progesterone could give us a negative effect in the growth of the endometrium, and that's the reason because we prefer to use progesterone in all the cycles that are not considering the fresh embryo transfer. Fourth step, we need to choose the ideal medication for the triggering or the trigger of the oocyte maturation. And we have 2 options here. The first one is the HCG. It's the classic medication that we have been used for a lot of years. And we have 2 compounds, recombinant and urinary HCG. And the second one is the GnRH agonists. What about the HCG? There are no relevant differences between recombinant and urinary HCG. You can use 5,000 units, and that is enough for obtaining a good maturation rate, and is more safe compared with 10,000 units. By the other hand, the GnRH agonists are indicated for diminishing the OHSS risk in high responders because the HCG is the main compound that could cause the hyperstimulation. The agonists give us protection for this effect. It's not recommended for normal responders and fresh embryo transfer. And there is emerging evidence that shows that the use combined with HCG, that is named dual trigger, could be useful in poor responders. Okay, and finally, the 5th number or the 5th step, define if the cycle will have fresh embryo transfer or if the cycle will go to freeze-all. And we have some advantages comparing one option with the other. What about the fresh embryo transfer? We prefer to do the fresh embryo transfer when we have low risk of OHSS, if we have 18 follicles or less, if we have a normal endometrial thickness, it means a normal develop of the endometrium during the stimulation, low progesterone levels on the day, and usually we try to have a limit in 1 nanogram or less. There's the threshold for this criteria. And when we don't have indication for PGT. By the other hand, when we prefer the frozen transfer, if we have some type of risk for having any type of OHSS, when we have 18 follicles or more, if we have an abnormal endometrial thickness, if we have high progesterone levels on trigger day, and finally, if we have some indications for do PGT. And remember that when we know previous to the beginning of the treatment that the patient will go to a frozen embryo transfer, maybe the progesterone for blocking the LH could be the best option. There are other relevant topics that I want to share with you today, and it's the luteal phase support. And there is a strong evidence that show that the use of progesterone during these cycles improves the pregnancy rate and the results. Then my recommendation is in all the cycles of IVF and ICSI, you should use progesterone for improving the results. But there is a new concept, and it's a random start. What is that? That means that we can start the stimulation at any moment of the cycle. In the past, we thought that we need to start the medication and the stimulation only at the beginning of the cycle during the menstrual bleeding. But right now, we know that we can start the stimulation at any point of the cycle. And that could be useful, for example, in oncological patients, because that patients need to start very fast the chemotherapy or the surgery. And the oncologists are sometimes very, very concerned about the postpone of the treatment. But we know that we can start a random stimulation at any point of the cycle, and that could be a useful tool in this type of patient. And remember, please, that we must keep in mind in all of the stimulation cycles that the OHSS is a real risk, and we need to be sure about to identify the patient in risk, and we need to apply all the strategies for avoid the risk of OHSS. That's important to remember today. Okay, that's the information that I want to share with you today, and I hope that all of this lecture will be useful in your routine practice. Have a nice day, and I will be here for any doubt that you can have about this topic. Have a nice day.